both studies have demonstrated that Trop-2 ADC significantly improves outcomes in the first-line setting compared to chemotherapy.
In other areas of breast cancer research, the OS has actually played a fairly significant role in the choice of which of, let's say, more than one choice of drugs within a class that we use. For example, first-line CDK4/6 inhibition in hormone receptor positive metastatic breast cancer, the ribociclib plus AI first-line trial had an OS benefit that was statistically significant, while the other two CDK4/6 inhibitors failed to achieve that goal, although the abemaciclib trial had a p-value of 0.06, so it was a really close call. But in as much as guidelines committees like ASCO and NCCN and ESMO, they use not only the robust nature of the efficacy signal, but also the level of evidence of that signal. So is that going to play out here, do you think, that the OS that we already have in TB02, that's done. It's statistically significant. And that's the holy grail in solid tumor oncology, is level one evidence of an OS benefit with statistical confidence. And we may never achieve that with the ASCENT-03 trial because of the crossover. So is that going to be a distinction in terms of guidelines?
So that is also a very important question, a very good one. And I think, so we have to think about it also in the context of the breast cancer subtype. And this is metastatic triple-negative breast cancer.
Yeah.
And unfortunately, we know that about 25 to 30% of patients diagnosed with metastatic triple-negative breast cancer are no longer alive at 6 months for their metastatic diagnosis with standard chemotherapy. And so a medication that is able to significantly prolong progression-free survival with an acceptable toxicity profile should be sufficient to change the current standard of care in the first-line setting, irrespective of OS advantage. And I think both studies met their primary endpoints. And there are going to be limitations in the interpretation of the OS data from ASCENT-03 because of the crossover.
Right.
But I do think that including the crossover was a very important consideration. The drug SG is approved in the second line and beyond, but about 2/3 of patients enrolled in the study were enrolled outside of the US and Canada and Western Europe, where there is more limited access to these agents.
Okay.
And so there were the ethical considerations as well, right, of including the crossover therapy. And so it's going to be very hard to to compare the OS data between the studies, given the high crossover subsequent ADC rate use. So it'll be important to see how the guidelines list these agents. But I think that essentially both studies have demonstrated that Trop-2 ADC significantly improves outcomes in the first-line setting compared to chemotherapy. And this is really changing the treatment paradigm of metastatic TNBC. And it's the outcomes, the improvements in outcomes. I think the data that we saw from TROPION-Breast02, very consistent PFS, OS benefit response rate, and the consistent benefits that we've seen with SG for PFS as well. These all support prioritizing the Trop-2 ADC in the first-line setting, right? Okay. Because given the poor prognosis in this patient population, we should prioritize the Trop-2 ADC.
Certainly.